Hi everyone, I'm Emma Stanmore and myself and Millie Parchment will be sharing with you an update of the Greater Manchester scale-up of Keep On Keep Up. This is a digital NHS approved programme and it's to prevent deconditioning falls and frailty and is known as COCU for short. I just want to very quickly acknowledge the funders for this research and development, which you'll see from the various logos have been from a variety of national and regional science and research councils. The majority has been from Innovate UK and NHS England, who are funding us at the moment. I also want to thank all the contributors and collaborators, of which there are many. These include health and social care providers in Greater Manchester who've been willing to pilot COCU and provide valuable insights around implementation. Just to recap for those who may be less familiar with COCU, the idea behind the development was to co-create a digital tool that can be used by health and social care professionals to supplement their current provision of services for older adults. Or it can be socially prescribed for an older person to use independently at home if they can safely use a tablet or an iPad. It's not designed to replace, a face-to-face person or for somebody who would, be better going to an exercise class like the strength and balance classes. But it's to really, to improve, say, giving somebody a leaflet, or for those people who actually can't get out to these kinds of classes, aren't getting any support at all. And as well as involving older adults in the design, we've collaborated with experts from later life training, Manchester Falls prevention teams, and also academic experts. As the COCU programme is based on the well-known Otago and FAME exercises that we know from hundreds of clinical trials reduce falls by around about a third, and they can improve function in our user groups. And working with these experts has enabled us to capture the precision and control needed for the exercises. So they're explained, they're animated. You can see the animated coach here who we work with older adults to make sure that they were happy with the design of him. They didn't want to see an image of themselves or an instructor. And the messaging about the exercises, they're demonstrated by the coach, but there's also written and audio information just to help those with sensory impairments. And there's lots of safety advice in there as well about the best way to complete these exercises at home if they're on their own. The first download of COCU explains how to use it. That's just for the first time, so it doesn't annoy people by repeating that information. And it asks a few questions to be able to personalise it to each person. So at the start, we've got 4 descriptors that can be selected to ensure the right level of exercises is followed. And the programme starts with quite light, easy seated exercises and progresses to much more challenging strength and exercises over the 12 weeks use. An advantage of digital programmes is you can embed health behaviour change techniques to increase engagement and adherence. Here you can see a home safety game. We've used gamification and just to get the information across that's more engaging really than what people find with things like leaflets. And although you can see from the game it's very easy, they can tap on items that may be a fall hazard at home, it follows with evidence about modifications and also a bit of humour, so it's a bit more fun to use, because we know that busy healthcare professionals may not have the time to cover this type of information in day-to-day practice. And we've got these health literacy games on bone health, hydration, and 2 being developed on brain health and malnutrition awareness, all following, say, NICE guidelines and other national and international guidance. And you might be familiar with techniques such as nudges and reminders to use, using digital programs. But the gamification, it also adds things like rewards and feedback and progress charts. So again, that just helps with engagement. The design of COCU has been tested and validated with older users. We've had quite a few studies now completed where we just keep improving it according to feedback. It's an iterative design. So things like the size of the font, the bright colours, even the icons have been adapted according to the needs and preferences of our users. COCU is classed as a wellbeing level device, and we've worked with NHS Digital right from the beginning just to make sure that it's compliant with safety and regulatory standards, and it's got the necessary approvals and follows the NICE digital health technology guidelines. And we've been very conscious about digital exclusion, so we've worked with social care providers and charities to ensure that our COCU users are able to loan a tablet or an iPad if they haven't got one, We've developed it in Android and iOS and made it available online and offline, so they don't need Wi-Fi once it's downloaded. We've been translating it into different languages, which is not as straightforward as it might look, because obviously the text and the fonts and things has to be changed to fit each type of screen. And we have also made some cultural adaptations too, because things like the hydration game, they've got alcohol in the fridge and information about alcohol, or pets and things as trip hazards, things that aren't really always culturally appropriate for different user groups. And our trials have always been with people living in deprived areas with a range of multimorbidities, so long-term conditions and sensory impairments. And that's, we wanted to widen the access as much as possible for our user groups. Moving on to the research, we've used mixed methods for the initial development and iterative testing of Koku, and then we've gone on to complete feasibility, acceptability and usability studies, where Koku is being used unsupervised for 6 weeks initially and then 12 weeks, either in people's own home with the support of carers and support of care providers, and also in assisted living facilities. So these are people obviously at high risk of falls. We've had results from separate studies in the UK, Greater Manchester, Nottingham, the US and Texas, and in Norway, and they're all consistently positive. Obviously we learn from areas where we think there needs to be improvement within Koku and are able to keep working on those. But we learned that people wanted more exercises, they wanted more games, more challenge, and so we've made those adaptations. And then these promising results have led us to move on to an implementation study, which is what we're currently working on at the moment in Greater Manchester. When thinking about who Koku might be suitable for, well, in our studies we've had people taking part who've been aged between 56 and 102. And I would say the people who benefit most, they are pre-frail to moderately frail. They're wanting and are ready to do something to try and stay independent and maintain that level of function. They need to be people who can be are willing and able to use an iPad or a tablet, and they could, that could be with a carer or family support if needed. As I mentioned before, many of our users have a range of long-term conditions, but they shouldn't be medically unstable or acutely unwell. It's not really there to replace a therapist, but it can be used in conjunction with a rehab program if it's under the direction of a therapist, and that is happening. But some people need very specific rehab programs, and this isn't designed for that. Some mobility is needed, so Koku is not suitable for people who use wheelchairs full-time for mobility needs. And Millie's going to share a few case studies that will help to bring some of our users, in different settings to life. We currently have NHS England funding to scale up Koku to 500 people in Greater Manchester, and we're making great progress with that, to also gain some user case studies and develop a data dashboard, which I've just got a bit of information about in the next slide. Here you can see the sign up screen and some screenshots from the data dashboard demonstrator. So we've worked with different stakeholder groups, and again with some expert input to agree the metrics and features. And we have a software engineer, Jane Sinnott, who's progressing this so that it will link up with Koku and be able to feedback progress through clear data visualizations back to care providers. And then in March this year, we sent out an expression of interest across Greater Manchester, and we had 120 individuals initially express interest, and of those 102 you can see across the 10 localities here have attended implementation sessions since that time. Of these 102 individuals, you can see they come from a variety of different sectors, but most are from social care in blue, followed by healthcare, and then in pink, charities. Providers are at different stages of implementation. Green are those who are up and running, amber are those in setup, and red are those in the planning stages, and we've got constant learning between the different groups. And here you can see the stages of implementation across the 10 GM localities, and Millie is going to share a few case studies across these areas and sectors. Thank you.
Hi, Hi everyone, I'm Millie Parchment. I'm a research associate working within the healthy ageing theme of the NIHR Arc for Greater Manchester, and I'm supporting with the scale up of COCO across Greater Manchester. So as Emma's mentioned, COCO's been implemented across the 10 different localities, and I'm here to give you some examples of the case studies we've been developing across different health and social care providers and organisations in planning, setup and up and running with COCO implementation. So we've been running implementation sessions for a range of organisations and providers across the localities and collecting feedback, and as I said, developing case studies for those in those different stages of implementation. And it's been really amazing to hear what they've had to say and the potential they see in COCO for helping the older adults that they support in many different ways. And we've also been reaching different cultural groups and communities, which has been fantastic really. So in Bury, for example, and I never know if I pronounced that word right, but we have the Federation of Jewish Services, also known as the Fed, and they're currently up and running with COCO implementation, and they're a social care charity for the Greater Manchester Jewish community. The Fed offer a wide range of specialist services for older adults, including community care, supported independent living, respite care, discharge to assess, nursing care, residential care, all the way to end-of-life care. And the Fed support approximately 1,300 individuals per month and house 157 residents and tenants at Heathlands Village. And I've been lucky enough to go and meet some of the team at Heathlands Village, all of whom are really enthusiastic about using COCO with the older adults there and within the community services that they provide. So members of staff from the Fed attended early COCO introductory sessions that Emma and I were running and expressed interest really early on in supporting the COCO Greater Manchester scale up. And that was with the aim of reducing falls, hospital admissions and further deterioration in individuals accessing their services. And key services identified for COCO implementation included community services and supported living and residential care. Since attending these sessions, COCO champions, a COCO lead and a COCO device manager were selected within the teams at the Fed in order to facilitate successful implementation. Then volunteers were identified to buddy up with residents and clients to work through the COCO 12-week programme together and provide support and assistance with that. And then we delivered COCO training to staff members in order to increase their confidence and competence in supporting the older adults to engage in the COCO programme. 10 eligible residents have since been identified who live at Heathlands Village, and they've expressed interest in initially trialling COCO, which is amazing, and 10 iPads have been funded by us at the University of Manchester to support implementation. The iPads have been received now, and COCO's been installed on them, and they're currently using COCO with these 10 residents, which is fantastic. And they're even organising a celebratory event for those who complete the 12-week programme as a little incentive, I guess. And if this initial trial is successful, they're looking at scaling up further across their residential and community services, which again is really fantastic. And here you can see some really positive and enthusiastic comments from colleagues at the Fed, the chief exec included. This was from when they were in planning and setup with regard to COCO implementation. And we're planning on having regular check-ins and updates and feedback from them as they implement COCO with the 10 residents that they've identified for this initial trial. So it'd be really interesting to see at the end of the 12 weeks how they've been getting on, and hopefully we'll be getting some feedback from the older adults themselves, which will be really useful. Okay, next we have an example of a provider that's currently in setup with regard to COCO implementation, and we thought a nice example from the Manchester Central locality is the African Caribbean Care Group. and they're a registered charity offering a day care and community service for people aged 50 and over. This is primarily for African Caribbean people, and that's to enable them to access culturally appropriate and affordable health and social care services and activities to alleviate the impact of isolation and loneliness. They support people with increasing high level of need, enabling them to maintain connections and social contact within the community, and other services offered include personal care and support, dementia care, health and wellbeing prevention services, and also fitness programmes. So the Chief Exec and Operations Manager at the ACCG attended initial COCU introductory and implementation sessions. That was to learn and discuss how they could integrate COCU into the services that they offer to the older adults they support. And since then, they've identified a team of colleagues to champion COCU implementation, which again is amazing. They plan to launch COCU within their daycare services to promote strength and balance in the older adults they work with from October. And they've requested support with funding for devices to help facilitate this. So we're currently liaising with them to arrange the transfer of funding for 10 digital devices to support in the first instance. And they've said demand for the programme is sort of likely to increase after an initial planned trial that they're currently discussing. A digital inclusion project officer who's been regularly attending meetings and advocating rollout really has linked the ACCG with further device funding opportunities to support COCU implementation in the longer run as they start to roll out further. And again, here's some positive comments about their plans for COCU implementation. Specifically, they're wanting to launch the programme to their older adults at the event they're hosting for International Older People's Day, and they plan on doing this early October, so that's really good. And finally, we thought another nice example from a different locality was Stockport, because they actually have 3 different providers that are currently in setup with regard to COCU implementation. So they've got Age UK Stockport, and that's an independent local charity working in the local community to support older people, their families and carers, and they offer a variety of services to help people live independently at home and in their communities. Also got Stockport Homes, and they manage the housing stock owned by Stockport Council, and their independent living services support older people to stay independent for as long as possible. So they offer housing support, safety support, sheltered housing scheme support, and community activities for older adults in Stockport. And finally, Viaduct Care is a not-for-profit GP federation owned by a number of GP practices across Stockport, and they offer a number of services that support these GP practices with the increase in demands on them. And these services include home visits, physiotherapy, self-care and wellbeing support. So commissioners, members of digital inclusion teams, and staff from several health and social care providers, including colleagues at Age UK Stockport, Viaduct Care and Stockport Homes, have been meeting regularly to discuss COCU rollout, and that's after initially attending the introductory and implementation sessions. Again, they expressed interest very early on, which was great. Did You Know and StartPoint are a digital inclusion charity that have agreed to manage devices funded by the University of Manchester for COCU use in Stockport. Several champions have been identified across the 3 providers, and COCU champion, I guess the roles of the champions are to alleviate technology concerns, promote COCU and support older adults to engage with the programme. So devices, screen protectors, bumpers and service charges have been costed, and they've raised an invoice and yeah, the funding's just about to go in for them, and we're sort of transferring that in 3 rounds to fund 10 devices per round, and that's based on current demand and feasibility of implementation across Stockport. So Age UK Stockport plan to implement COCO across a number of services offered to older adults. They include the confidence walks that they offer and their discharge from hospital services. Stockport Homes plan to implement COCO with older adults in their independent living services, and Viaduct Care plan to implement COCO with older adults within their self-care and wellbeing support service, and also their social prescribing work.
Hi, thanks very much. Thanks for asking me to talk about our strategy. I'll crack on with it because time's of an essence. Next slide, please. So from a background point of view, from a Wigan point of view, as a borough, we have the highest percentage of people over 65 within Greater Manchester. And as we all know, our ageing population, but it's expected next 15 years, the 85 plus population have grown by 65%. Within Wigan, we have 52 care homes at present. I think there's 3 being built extra ones being built at the moment. So at the moment, we've got 2,200 beds. We've got really high occupancy as well of 93%. One thing that we've worked across Greater Manchester for a number of years, there's some evidence to say that only 20% of the population who actually are falling or injurious falls are coming in contact with any health and social care professionals. And of that 20%, only 35% attend hospital. So this is why it's so important as a community public health approach, really. If we just concentrate the number of patients going to hospital, and that's what it's measured by, it works out about 1.5% of the over 18 population of Wigan. Next slide, please. So, case for change. Going back to 2017, we'll all know the Public Health England databases that measures falls. And that is, the measurement is on the number of patients admitted to hospital with a fall, and then we look at fractures, etc. So again, it only touches on that, and unfortunately that's one of the things that it measures on. Wigan has been the highest admissions with falls since 2017, maybe before that. So we looked at this a couple of years ago. 18-19, we did have the lowest preventable mortality from falls. However, we're not complacent with our numbers. They're going up and up and up, and we needed to know what we needed to do. And this is our case for change, really. We need to change falls to be everybody's business. It's not just a small health specialist service. It's everybody's business across the borough. Next slide, please. So what we did, I did my professional doctorate at Salford University, and the impacts of that study, it was focused on falls and ambulance call-outs. But from the impacts from that study about people not acknowledging the risk of falls or what we could do about it, and obviously we know lots of studies have gone on about people not wanting to talk about falls and use the F word, etc. So what we did is, as a collective across Wigan, we wrote a falls strategy. So whose responsibility is, what your responsibility is, and what we need to be doing. And this covers obviously a WWL, right to Wigan and Lee, the Wigan Council, North West Ambulances, the Mental Health Trust as well, all our voluntary sectors. We've got Be Well as well in the council as well. So everyone we could get involved got involved. What we needed to do initially is the FRAT risk assessment tool that's been used wasn't really fit for purpose. The questions were great, but they didn't lead on to the right thing. If somebody scored 1, they may go to Be Well for exercise when it could have been a blackout. So it wasn't clear. So we changed it, and we've changed it. I know we'll be sharing these slides, to a falls conversation, just changing the conversation. And I know we can have arguments about which language you use for falls, etc. But having a conversation about falls rather than you've had a fall or you're high risk of falls, have a conversation. Are you worried about it? Would you like to become more active? Would you like to get out and about? So have those conversations, and that conversation leads into being seen by specialist service as required, such as blackouts, dizziness, and fracture liaison, come to our service in Wigan. If it's a balance or an environmental problem, it goes to community therapy and our early intervention teams to do a multifactorial assessment, then onwards to referrals as well. So we've changed the narrative, and I'll talk about the training in a minute, and we've tried to look at that from really just a population point of view. We've also, as part of the specialist training, and obviously based on NICE guidance, it needs to be by specialist trained staff, but across health and social care. So I've rolled out the training to a larger amount of people across the borough, so more and more people have access to that specialist multifactorial assessment. Next slide, please. So this is kind of our ICS, integrated services. This is the 20% really. It's the 80% that we're worried about, and there's lots of public health work going on that, and I know our Be Well teams at Wigan as well are doing a lot of work with that. So from the triangle, the yellow part is the self-care and prevention. So that includes like Be Well, Home Safe, Air Warm, Handyman. So anybody's in touch with anyone there, they will have a conversation with someone. From the green downwards, so active care is community therapy, early intervention. Complex is falls and fracture liaison service, our community neuro and stroke. The rapid responses, our community response team, and we also have, since 2019, set up a falls pathway for MWAS, so anybody's had a fall or high risk of falls can be referred in, and that's the last audit to that showed 84% of people being referred after a fall. And then the inpatient area, everyone's the updated and trained to do multifactorial assessment in that and then refer on. So we've got a wider population of staff who's specialist trained. Next slide, please. We've also got, and this is what there's been a lot of talk about this last few years, and it was informed from the research as well. Long lives. We know we've got long lives across the board. So I have been trying for a couple of years to get a lifting service in place without success, unfortunately, without funding. However, recently our Community React team did do a small pilot, and these are some of the figures they've got. They did reduce the numbers they saw, which were quite small numbers, did reduce along lives. However, 49% of those patients actually did have to go to hospital. They were medically unwell enough to go to hospital. It couldn't be managed in the community. So we've got small scale, but there's always funding issues with these as well. Next slide, please. So training so far, all this training took place over COVID as well, so it was really difficult. So what I've been done is a falls conversation. I did a quick 10-minute video talking about the strategy and talking about the conversation and have that conversation. That's been rolled out to a large number of staff and all the services here, like I said, Be Well, link workers, community coordinators, reablement, assistive technology, etc. They've all been rolled out to have that training. Also provided training with some of our practice nurse ACPs and first contact physios in primary care, and the multifactorial assessment training. Between that time, they're the numbers that I've trained within the teams. We're rolling this out further to do more like cascade training because we've not got the capacity to keep updating training and new staff. So there's, as you see, there's a large amount of people know this, and this is how we've rolled out the training. Next slide, please. What we developed as well is a dashboard. It is important to look at numbers for admissions, but it's not everything, and it's really frustrating to look at that. So we wanted to look at what does it mean within this strategy? What's the quality we've added as well as other data? So we've got pathways in place, number of people assessed at initial assessment. Of those, how many of those had a falls conversation or a multifactorial assessment, depending on the teams and who are trained. Done 2 yearly clinical audit. We've seen a much improvement in that within auditing of multifactorial assessments, because traditionally there's a major issue with postural blood pressure not being checked. And we've also got quarterly case studies from each level to what we're doing. From a people point of view, we're looking at some outcome measures, which obviously there's various validated outcome measures. across the council and across health as well. So we're developing that. We're developing a feedback form, not just to, you know, friends and families, more NHS. We're developing at the moment how we can look at that, and we've been trialing that. And from a council point of view, they're just really looking at volumes of adaptation, support, etc. from a falls point of view. And from the hospital, we are looking at the figures of admission, admission avoidance, but also inpatient risk assessments, etc., and inpatient harms. Next slide, please. So ongoing developments, we've been trying again to have more specialist service provision for our care homes. Our lead for care homes and the Falls team and quality work, done a few sessions to some drop-in events this year for care home staff for training. But we really need that specialist team, and we're working on that. Falls dashboard, there's still ongoing problems and analysis of the data. We have got the report for this year. We did see, and I didn't put on this because it would not reported, but we had seen a reduction in the last year of admissions with Falls overall, which is really positive. But obviously we've fed all this into the GM Falls Collaborative and working closely with them. Next slide. That's my reference. Oh my God, that is really quick for me. Thank you. Thanks.
Brilliant. Thank Christina. And great that you were quick today, because we did need to catch up on some time.
And you was worried that I'd take over. So yeah.
No,
10
not
minutes,
at all.
10 minutes, 20 seconds. I've counted myself. Thank you.
Thank you so much for taking us through the fabulous work that's going on in Wigan. I am conscious of time, so I'm just going to ask if there are any quick immediate questions. And if there is, if you could just raise your hand. If not, I'm sure Christina will be staying on the call and can answer those in the chat if needed. Well, we do have one question. Trish, would you like to come in?
No, I've put it in the chat, but it's just a very quick question around the links with the sensory team and visual impairment in recognising falls.
Right. Okay. Yeah. That's fine. I'll answer it in there. Thanks, Tom.
Brilliant. Thanks, Christina. If we've no further questions, I'm going to hand over to our next speaker. So we've got, if it'll let me move on, we've got Dr. Helen Hawley-Haig from the University of Manchester, who's going to take us through the delivery of strength and balance and hybrid approaches. Thanks, Helen.
Hi. Okay. Yep. So this work is based on research that was funded through the NIHR, but also some work commissioned by the Chartered Society of Physiotherapy. So next slide, please, Beth. So I guess the question is, why remote or hybrid approach to delivering strength and balance? Well, the two most evidence-based programmes that are delivered in the UK are the Otago and FAME, but we know from evidence that there's often modification of the programme, and we have an issue in terms of dose and frequency and progression, and also maintenance of strength and balance that we need to get the outcomes. And technology has the potential to provide support for this in terms of dose and adherence. And actually, our Flexi study across Greater Manchester, which is about the implementation of FAME, has shown that there are issues with capacity for delivering FAME and also maintenance of FAME. And we have one site who does use Zoom to deliver a maintenance class. And I know that Emma has talked about Koku, and there's one other app available, a Otago Swedish app. But those are the two really that are currently available. All the others, and I have one related to rehab, are going through the research phase at the moment. And we know that for people who are either seeing an exercise instructor and receiving FAME or having Otago through rehabilitation, they should have a tailored, personalised and individualised programme. And really, this often needs a person at the other end to achieve this. We know that the COVID-19 pandemic has demonstrated that a remote or hybrid approach to either delivery of rehabilitation or strength and balance exercise has potential and has worked. So what evidence do we actually have that remote methods might work for falls and delivery to older adults? So next slide, please. So we did a rapid scoping review for the Chartered Society of Physiotherapy during the pandemic, which did focus on physiotherapy, rehabilitation exercises, and the benefits of delivering remotely could help access in terms of people not having to get transport to attend clinic. Compliance and adherence. So we know that digital methods are quite good for compliance. This is partly related to the novelty, the enjoyment, and depending on what it does, can be real-time feedback. And for some people, it does help access, partly related to not having to travel. The barriers are around connectivity, usability of devices, security, safety, and confidence by both health professionals and instructors and older adults to use the technology. And we also know that it can lead to a loss of physical and social aspects and personal touch. So next slide, please. So overall, when we looked at remote delivery, we knew there's strong evidence around cardiac, stroke and MSK rehabilitation in terms of systematic reviews and trials. But for other populations, really, there was a mix of different study designs and different outcomes. So it's really hard to come to firm conclusions. And very little is UK-based delivery by our actual services. What we have found, though, where it has been measured, is that it is equivalent to standard care. And no adverse events were reported. And you have to remember that's often a real issue with engagement with digital, this risk of falling actually while doing it remotely. And actually remote physiotherapy has been found to be less costly, but we have to remember there's been no cost effectiveness, so we don't know if it's as good. Older people specific, there's even less around older adults rehabilitation and falls. But where it has been done, the findings are pretty similar. And not included in the review, but additional papers we found, there was some evidence around remote delivery of Tai Chi as well, which we know is important, strength and balance. So next slide, please. So the only paper that, as far as we were aware, there is around teleconferencing for falls rehabilitation is actually one that I did in 2016. How did I know before the pandemic? And this is where we used Skype and Google Hangouts to try and deliver falls rehabilitation. I had a couple of reasons for doing this. Partly, I was interested in if it could help progression and exercise dose. And secondly, also, whether there was an option for remote delivery to encourage, by group, to encourage people to then go into a real group in terms of confidence, or also once the health professional had stopped delivering, if small groups would continue to support each other to do the strength and balance. It was a really small study. We only ended up recruiting 7 patients, and we worked with one full service for testing the equipment because we provided the technology. And but we also sort of presented the concept to 2 other services in Manchester. And overall, we found that it was acceptable to patients and health professionals, but there were massive issues in terms of reliability related to connectivity and Wi-Fi. And in fact, that did link directly with digital exclusion. So the particular barriers were in deprived areas. People had their landlines taken out and were reliant on 3 and 4G, which also seemed to be terrible in those particular deprived areas. There were also issues with view, positioning and safety, particularly for the delivery of dynamic balance exercises, where you could either see somebody's feet or their head, but you couldn't see all of them in view at the same time. And the group-based teleconferencing just presented even more challenges. The view was even smaller with multiple people. Well, we only tested it with sort of 2 patients on the line, and also it also caused increased issues with connectivity. So it was a challenge. Next slide, please. So when the pandemic happened and there was the opportunity to tender for the evaluation for the CSP, I was really interested to see if things had changed since I'd looked at this in 2016. And in fact, we had 1,620 responses to our initial survey, and then we did some case studies with where we selected sites. So next slide, please. So we had a really good range of responses across all clinical areas, from children all the way through, and in all sorts of different settings, so private, community and hospital-based delivery. So it was services leading digital delivery. And actually, interestingly enough, Most delivery was through teleconferencing or telephone, and actually for falls or older adult services, none of them used apps. So the apps tended to be COPD and heart failure services. Next slide, please. And they did use it to deliver both one-to-one, so just over 50% delivering one-to-one exercise, but also to deliver group exercise as well. Next slide, please. So our full specific data, we actually had 151 services respond who either were full services or actually delivered community rehab, so delivered services that included fallers. And half of those came across real challenges to delivering remotely, but most did overcome these. But we have to remember that during this time, during the pandemic, there were a lot of older adult services were redeployed, particularly community services, or due to the nature of what they were doing, they were allowed to see patients still face to face. So the challenges for the full specific sites were actually very similar to across the broader cohort. It was around access to Wi-Fi equipment, and delivery with people with sensory limitations was really difficult, or cognition issues, or where English wasn't first language. There were technical infrastructure issues massively for staff, partly because a lot of them had gone to people's own homes, so they weren't set up to deliver remotely and they didn't have Wi-Fi in the buildings. Familiarity with platform was a big issue for our older adults. They wanted to use Zoom, but for our NHS services that wasn't allowed. It worked quite well for follow-ups and triage, but it was challenging for assessments, particularly related to cognition. And where people delivered from a clinic-based setting, they found it great to see somebody's own home. But where they normally went to that person's home and was in their own environment, then they didn't feel that it was as good as actually being there, and they were worried about missing additional things, particularly if you think about a holistic approach to falls and falls risk. So the conclusion was really that it enhanced really rather than replaced. And a lot of our patients found it acceptable, but only saw it as a stopgap. So next slide, please. So we did a particular falls case study where we worked with a service who delivered a 6-week virtual rehab program. And this was delivered by one rehab assistant and one therapist with up to 5 patients. And they do an initial remote or in-person visit to do an assessment, and then an induction where they help the person to use video conferencing and a careful risk assessment. And actually it was really important that that planning was in place and they were very prepared in terms of what they did. Next slide, please. We asked them about their outcomes, so they didn't give us the raw data, were basically based on what they gave us, but we looked at their in-person delivery, so they used to deliver classes out in the community, to the remote delivery, and the ages were similar, age range slightly broader with the in-person, and uptake, attendance and adherence was actually slightly better for the remote delivery. But you have to remember, this is at a time when older adults were shielding, so you kind of got a captured audience, and obviously they didn't have to travel, but they did get really good feedback in the qualitative evaluations that they did. Next slide, please. So we asked outcomes again. We weren't given access to the raw data, so this is what they have given us. And obviously there's real difference in number of people who had gone through the virtual program by them and their data for in-person. But they collect a big balance scale, 30-second sit standard falls efficacy, slightly better for remote services for leg strength and for fear of falling, but the Berg balance was slightly better, not clinically significant for the in-person. Again, not surprising, because when discussing it with the service, they had limited their dynamic balance for delivering remotely due to risk. So it's not surprising that maybe isn't quite as good. Next slide, please. So overall, we found that effective leadership, appropriate resources, a flexible approach and a thorough planning are essential for delivering a kind of remote or hybrid approach. but there is no evidence that a remote blended delivery is unsafe or less effective than in person. But you have to remember the people who are chosen are very carefully triaged, whether that's through a trial process or clinically by a health professional. Remote should become an important but not the only part of somebody's toolkit, and that we should use it where it can increase reach. But bear in mind that it is good for some, but it can also exclude others. So our health professionals were really surprised how many older adults they could actually deliver it with. So we recommended a blended approach and putting the patient or the person at the centre of that decision making. So where are we going next? We have a PhD student at the moment in the team who is looking at the implementation of the FAME programme, and that includes digitally. From the evidence, she's only found that one paper on teleconferencing and another one of Emma's on the exagaming for supporting remote delivery. She is interested in looking at how that technology can promote uptake and adherence in men, because they particularly, our evidence is that they can feel quite intimidated in quite women-dominated groups. So it's an option for FAME delivery. But it's really important that we consider the right person, the right technology, the right intervention at the right time. And that's something our team in Manchester is really looking at to try and make sure that message gets across. Okay. That's me, I think. Oh, I've got some resources, but you can see them online. So there's some links after that one around links to things around remote delivery.